feature and let us know what questions and comments you have throughout the session there. My name is Kyle Chang. I've been a dialysis patient and somebody with CKD since 2013. I was one of those patients that LeVar and the other folks know well that I crashed into dialysis. I ended up into the ER for totally unrelated reasons, and then they pulled some labs and then told me, hey, guess what? Your kidneys are failed at one hospital, and then I didn't quite trust that hospital and asked for a referral to a different hospital, and they said, no, we don't do that. And I said, well, I'm checking myself out and heading over to the other hospital across town. And got reconfirmed with my diagnosis. I've done over 5.5 years of dialysis in total on in-center hemodialysis, peritoneal dialysis, as well as home hemodialysis, and do a variety of different patient education, as well as advocacy work with American Kidney Fund as one of the organizations, and also Home Dialyzer United, moderating different groups, including Peritoneal Dialysis Support Group, Home Dialysis Central that Dory is part of with MEI, as well as working with the AKF advocacy team. You get one of these pens if you're one of our advocacy ambassadors, and also a certified kidney health coach with American Kidney Fund. So that is about me. Stephanie, I have done it all, a little overachiever in dialysis and nephrology here, and about to have a second transplant going through that. So I've been transplanted, and that's news for Dory. She's got the shock face there. I got one transplant from a deceased donor back in 2019, and recently got labs where it looks like I'm going to have to look for a second transplant or go back on dialysis in the next few years. So that's a little bit about myself, but let me introduce some of our other distinguished panelists and speakers. Tracy Amaldi is similar patient advocate and also home dialysis patient previously. And she is a 2-time transplant recipient, was diagnosed with FSGS back in 2006, and went into end-stage renal disease. She had kidney cancer, similar to myself, and her time for kidney cancer diagnosis was in 2008. In 2013, she was doing mostly in-center hemodialysis, and also received a living kidney donor transplant thanks to her son through a living donor exchange. And there's other sessions today that you can learn more about that as well. And also, sadly, in 2021, she lost that transplant and she found herself on dialysis for the second time, but this time she was able to be the first patient on the Tableau with Outset Medical. So that's a different home dialysis machine that is available. We'll talk more about that shortly. And in February 2022, Tracy received a call and got her second kidney transplant. So we'll wait for her to reconnect back to the session, and we'll ask her some additional questions for that. Nurse Adam Wilson is the Director of Home Dialysis and Vascular Access at USA Clinics Group, the parent company of USA Home Dialysis. In Adam's 20-plus years of clinical health care experience, he has focused on care model improvement, mentorship, and coaching of clinical professionals and implementation of evidence-based interventions and practices. His specialties include chronic kidney disease, end-stage renal disease, AKI, acute kidney injury, hemodialysis nursing care, and nursing staff development, and of course, vascular access management, transplant preparedness, and patient self-care support systems. So we thank professionals like Adam and his colleagues for getting well educated and helping others get educated in the industry to help keep us in the patient community alive and healthy. Dory Chantel has worked in the kidney field since 1989, since she was a teenager. She's been doing this quite a while as well, and she focuses on talking to folks with kidney disease and learning what life is like for them. And she's helped me a lot throughout my kidney dialysis journey, and also working with advocacy and speaking and education as well, from early on in dialysis and running support groups. She's talked with and emailed over 20,000 patients with kidney disease and their loved ones, care partners. She uses what she learns from people and from research to develop evidence-based education to empower folks to feel as well as they can and live their best lives. And Dory is currently serving as Executive Director of the Medical Education Institute, MEI, through which she directs the Life Options Program, Kidney School, and Home Dialysis Central. So thanks everybody for joining us. And while we wait for Tracy to reconnect here, maybe we'll skip ahead on some of the questions. And once again, let's go ahead, and I see some questions already coming in through the room chat. We'll go in, and first one from Refugia is asking, please explain the types of peritoneal dialysis and how and who determines the type of PD for the patient. You know what, Dory, I think this might be a good segue for some of the things that you presented earlier in terms of the tool that you have available, if you want to recap the tool and then what's on there, and then talk a little bit about peritoneal dialysis, and then we'll have Adam maybe chime in a little bit from his experience as well. So Dory?
I was going to say I thought it sounded like a good Adam question, but that's fine.
Oh, yeah.
Thank you, Kyle. Meanwhile, I wasn't a teenager. I'm now a teenager, but I wasn't one in 1989.
You still look so great and so young. So.
Also, we don't have kiddie school. If anybody's following the what do they call it? The transcript that it's doing live. I click that on. It says kiddie school instead of kidney school. I'm like, no, kiddies don't need no schools. They already know what to do. We all need schools. So peritoneal dialysis. There are two different ways to do it. Historically, most people did manual PD exchanges. So 4 times a day, usually breakfast, lunch-ish, dinner-ish, bedtime-ish, they would connect and do an exchange. And that would be manual, and there wouldn't be a machine involved. PD would be going on all day long, but there would be 4 times a day where you have to stop for about 20 minutes and do that exchange. And it has to be sterile every time you do it. So, it's important to do it correctly. Over the past, I want to say 5 years. There. Did y'all lose me? Was I gone, or could you still hear me?
Dory, it looks like you froze up a little bit. Yeah,
it booted me
kicked
out.
everybody out.
It did. That's the second time. At any rate, over the past 5 years or so, there has been this sea change toward peritoneal dialysis using a cycler machine. So that's only done at night unless there's also a daytime exchange. And it's it's fewer connections. It's generally, studies find better quality of life, but really that's very individual for a person. And I would argue that what matters most is what makes their life work best. And for some people, a cycler makes their lives work really well. And for other people, they get drain pain with a cycler that's difficult to deal with, or, various things happen that just don't make cycler PD work as well. In which case, manual PD is always an option if you can do PD at all. About 2/3 of people can do PD.
All right, and Adam, if you can hear us, what's your perspective on peritoneal dialysis there?
Yeah, guys, I don't want to get over my skis here. I am 99% hemodialysis trained and experienced. Dory just gave some phenomenal responses there, and I'm just going to leverage and really piggyback off some of the comments that were already made by Nelchi, and that's, you need the modality that fits your lifestyle. You need the modality that fits the freedom that you want. You need the modality that fits, as she put, a lot of life and a little bit of dialysis. So we don't want dialysis to be this much and our life to be this much, right? We want it the opposite. So The PD modality does require typically more frequent treatments. As Dory just alluded to, most patients do the PD 6 to 7 days a week throughout the nighttime. I will say for those that have more residual kidney function and really want to preserve that, I would assume that's the goal, right? Is to preserve that renal function that you have. PD is a great option because it really does help a cardioprotective and deliver a cardio soft, if you will, approach, whereas hemodialysis can be a little more taxing on the heart. And conversely, for those who seemingly have a fluid intake struggle, PD can be a challenge because fluid is removed much more easily through hemodialysis than it is through PD. And so, again, you're going to get some mixed opinions on this, but again, I'm not a PD expert and don't pretend to be. So maybe Tracy can talk about PD. I'm not sure, but that's not my cup of tea.
Yeah, Tracy, you can hear us, correct? I know we have some audio issues and technical difficulties, and we have over 171 and growing folks joining us in the session, so maybe we're crashing the system of the session a little bit. I just want to let you folks know that if you have audio issues, go ahead and refresh your screens. Also, use the room chat. Continue to do that. We'll try and catch as many of the questions that we can during the time we have in this session with panelists. We also have a peritoneal dialysis specific session to give you a little bit more background later on today with some folks on there. But I did most of my 5.5 years on peritoneal dialysis. Tracy, did you have experience with peritoneal dialysis?
Not peritoneal, but
can I hear you, Tracy?
You can't hear me? You can see me, right?
Tracy, is your mic muted? Is there a little slash line through it?
Can you hear me
A
now?
little red line through the mic on the bottom, down below all of our pictures.
Okay, looks like Byron is able to hear and see Tracy, but for some reason we're not able to.
That's weird.
It's weird. Yeah, something going on with the system. Apologize for folks. Let me jump in and fill in the airtime here a little bit. I saw some questions in terms of cycler size. Peritoneal dialysis cyclers range in size as well as weight. It could be anywhere from about 25 pounds to about 35 pounds on average, depending on which company you use and which cycler model you have. And then let's see, we'll go back through the room chat a little bit about peritoneal dialysis cycler. Oh, I did see one question earlier about which option is more flexible in terms of the dialysis modalities. Again, there's peritoneal dialysis, in-center hemodialysis, in-center nocturnal, as well as home hemodialysis with different cyclers and machines. The home hemodialysis cyclers tend to be larger and heavier at approximately 99 pounds with the next stage. Both peritoneal dialysis as well as the home hemodialysis cycler from next stage are pretty travel friendly, besides the weight difference as well. The Tableau does not travel as well because it's a much larger unit on there, but it is very effective for the patients that's working on those systems if they're not doing in-center. And for me personally, over the 5.5 years on dialysis, I found peritoneal dialysis to be the most flexible for my lifestyle, being active and business owner, since I was able to switch between doing manuals as well as a cycler at night. Typically, you do cycler treatments at night with longer periods, and also, as Adam mentioned, more days during the week. So it sort of depends on your lifestyle, and then the tools that Dory and MEI put together online, as well as your clinician can help you make the decision of which modality might best work for you. All right, I think that covers a lot of the questions that jumped through the chat. Let's continue. What are some case scenarios for Dory and Adam in terms of that you've seen for somebody that can deal with the diagnosis of kidney disease? I know I was really shocked when I was diagnosed, and I sat at the hospital for about 3.5 weeks trying to ponder life on that when I crashed into dialysis. So that's a pretty scenario, crazy scenario there. And thinking everything's over and realizing, oh, slowly that acute dialysis center, it's actually keeping me alive and I'm feeling better. What are some other case scenarios that you've seen or heard of from other patients and caregivers before they go on dialysis or transplant that you might be able to share with folks? And what are some proactive steps that folks to plan for the future? Adam, let's start with you.
Yeah, Kyle, a buzzword that you use there is crash into dialysis, right? And all of us on this side of the fence who are care providers in nephrology, this is typically the scenario and what happens with patients in CKD. As the data indicates, about 90% of patients who have kidney disease don't know they have it. So it's a largely underdiagnosed disease process that a lot of people just seemingly don't have until it's, or don't know that they have until it's late in the game. So that whole crash into dialysis really underscores the importance of following up with your PCPs with the two major empirical data points being hypertension and diabetes. So if these things run in your family, if you've been diagnosed with these, as a dialysis nurse myself, please, I can't stress enough the importance of following up with your care providers and managing your diabetes and your hypertension, to where we are no longer having these scenarios of crashing into dialysis. It's not a crash. We know what's ahead. You can plan ahead. And along those lines, since I am a vascular access nurse, planning your access options way ahead of time would also be crucial for your plan. But countless case scenarios, Kyle, as you asked about, countless case scenarios of patients really putting off to the last minute to the point where it does become a crash. Yeah, really, it's just if we can prevent that stumbling into crashing ER experience. Oh my goodness, I wasn't ready for this. I wasn't planning for this. I'm now in the ER. They put a catheter in my neck. I don't even want hemo. I want PD, or vice versa. I don't want this catheter in my neck. I'd rather have a permanent arm access. And by that point, it's really now the system is just dragging you, right? Because it's too late in the game. So that's really what I would stress as a provider is plan ahead. Please know your options ahead of time. Know where you're at in your CKD process, what stages you're at. Know your labs and where you're at in that CKD process as well. Ask questions. Become a very good question asker of your care team, whether it's your PCP or your nephrologist, of where you're at. When is it time to start really considering that next step in the disease processes?
And Dory, I'm not sure if you're able to hear me. I'm having issues hearing you folks, so I'll adjust there. But maybe you could go in and talk about some of the scenarios that you talked about and some things that would be folks that could prepare for themselves a little bit better. Go ahead.
I think that the most challenging thing about somebody who is facing a choice of an option for kidney failure is that nobody wants any of the options. Nobody wants this to be happening. Those of us who are really passionate about home therapies, because we see how well people do with them, how well they feel, how much better they do, how they're able to live their lives, we can kind of sometimes forget that. And so often what I see is a lot of folks coming at people going, oh, you should do this option or you should do that option. And it's like, that's not the way to make a choice. And fear is also not the way to make a choice. Fear-based choices tend to not be very good choices. But this is a time when everything is very scary. You know your life is going to change. You don't want it to. This isn't a choice that anybody would make if they didn't have kidney failure, right? It's not like you would sign up and say, hey, you know what sounds like fun? Dialysis, where can I get some of that? Nobody does that. Nobody wants it. You do it because you need it. But what we don't tell people is that the choice you make is going to affect every single aspect of your life, from how well you sleep at night to what time you wake up in the morning, where you're going once you wake up. Can you go to work, or are you going to be going to a clinic on somebody else's schedule? Are you going to be able to travel? Are you going to be able to raise puppies? Are you going to be able to drive a car? You know, to do whatever the things are that matter to you. And we don't teach people how to use those things as a frame for making a decision when any of the treatments can keep you alive, but some of them can give you a really good quality of life, and others of them may or may not. So the big paradigm shift is to think about your life first, to think about what matters to you first, to think about what makes your life worthwhile first, and to keep that in mind when you need to make a choice. And I stumbled into this by accident because there was a fella in a different Facebook group, not ours, not Kyle's, it was a different one. I think it was Dialysis Discussion Uncensored. And there's a fellow, I was like, you know, I fix motorcycles. That is my joy in life. I really love to do this. And now my kidneys are failing and I have to choose an option. What should I do? And, you know, everybody went into the usual spiel of, well, you know, you can do PD, but you need a lot of storage space. And, you know, you could do hemo and it's 3 times a week. And I'm like, no, let's think about what he said. What he said is he wants fixed motorcycles. What's going to be flexible where he's got the energy to fix motorcycles? What's going to allow him to stay clean to fix motorcycles? Like, all right, you know, you don't want to get too dirty with PD, but I mean, you can put on a shirt or you can cover up your catheter. Probably you're not going to get, you know, sprayed with gasoline or whatever fixing motorcycles. I said, you know, on the balance, it really sounds like PD might be a good fit for you. And that's what he chose. And he loved it. And he was able to keep fixing motorcycles. And I thought, I think I'm onto something here. You know, I think we've been doing this wrong because I was doing this the same way everybody was doing this. Here are the options. There's this and there's this. But if nobody wants either one, that's not a good place to start. So I will stop there.
Yeah, thanks, Dory and Adam, for your feedback there. I see several questions come in about vascular access. Adam, you made a comment in response there in the room chat for some folks, but can you elaborate on that, the different types of access that folks would have when preparing for dialysis options, whether it's PD, home hemodialysis? Talk a little bit more detail on that with the audio and video that we have. And then also there was a related question in terms of the doctor asked, you know, authorizing the vascular post-surgery, if you wouldn't mind answering that so folks don't crash into that. So, Adam?
Yeah, to start with the access issue. So folks, there are currently 4 main types of accesses that you can have as a dialysis patient. Primarily one with the peritoneal dialysis modality as a peritoneal dialysis catheter. And this, by the way, the peritoneal dialysis modality does not involve blood. Whereas the hemodialysis modalities do involve a direct blood contact. So the peritoneal dialysis catheter is placed generally in an abdominal cavity. So it's a catheter that kind of dwells in your abdominal region there. And the toxin exchange and the cleanliness process goes through the peritoneal cavity, and it goes through this cavity lining and then eventually into your bloodstream. The 3 accesses that are part of hemodialysis would be a what we call a permacath or a tempacath. It's a CVC, central venous line, central venous catheter. And those are typically placed in the right internal jugular or the left internal jugular based on your individual anatomy and where the IR doctor or surgeon can place that. So that's one of the hemodialysis accesses. And the other 2 would be a fistula. These are typically placed in the arm. We like to place them in a non-dominant side, obviously. We want to keep your dominant arm free. And a fistula is simply the marrying of an artery and a vein. So artery and veins typically don't directly connect, but a fistula connects an artery and a vein. It's manually connected through a channel, a connection called an anastomosis, and it allows arterial blood to flow into the venous system and really kind of beefs up that vein to allow the dialysis team to use that vein as a blood access to clean your blood. Then the last type would be a graft. A graft is a synthetic tube, so non-natural to you. It's a non-vascular component that is surgically placed in your arm or your chest. Some people have grafts down in their legs too, depending on your individual anatomy. But the graft then connects an artery and a vein and allows the dialysis team with needles to access that graft, again, pull out the blood, clean it through the hemodialysis machine, and return the clean blood back to you. So those are the 4 types of accesses that are available right now. And Kyle, I apologize. What's the second question you asked? Was it something from the chat? Kyle, can you hear me?
Let me go back to that, search for that, and we'll come back to it a little bit later. There.
Okay, I thought you asked me another question.
What are some of the best ways to sort of keep access safe and secure? Because part of your job in training with your clinicians and nurses is infection management.
Yeah.
What are some of the best ways and the type of different access? Best way for folks to prepare to care for them, whether they're doing it at home or through in-center. I've never actually had a fistula graft yet, so when I go back to dialysis, if I have to do that, that would be one of the other ones. But I had the CVC, I had the one over in the chest, both chests, as well as down in the groin area.
Yeah.
So and definitely PD. But if you could talk a little bit more about infection management, that'd be great.
Yeah, guys, your access is your lifeline. And we say that all the time in the dialysis world, but it's really true. It's like taking the battery out of your car. Your car cannot work without a battery. You cannot be dialyzed, whether it's peritoneal dialysis or hemodialysis, without an access. So it is critical. It is imperative. It's very, very important that you are educated about your access, that you know how to keep it clean, that you are adhering to the industry's best policies and procedures on infection prevention. Everything from washing your hands, hand sanitizer, soap, and water. Wash your hands before you manipulate your access. If you've got access to gloves, wash your hands and then put on gloves and manage your access that way. But really knowing the signs and symptoms then of an infected access, that redness, the increase in temperature around your access, so it'll get warm. Some accesses I've touched are hot. Swelling, you start getting a discharge, like a pussy, infected, white, yellow discharge coming from your access. Fever chills is kind of a really solid giveaway that there's an infection somewhere. So it starts with hand hygiene. Mask up, right? There's a lot of bacteria and pathogens that come out of your breath, the vapor in your breath that then drops because of gravity and falls on your access. So please, we stress this day in and day out. Wash your hands, put on a mask, and know the signs and symptoms of infection, because again, when that lifeline of yours is no longer able to be used, you can't dialyze. And so that puts you in a very risky, dangerous, critical situation. Dory, I don't know if you want to add anything to that, but that's what I would say.
I think you covered that pretty well.
Dory, I know we talked about in the home dialysis central discussion group a few times, there is starting to be a little bit of a trend of home dialysis. Some patients don't feel comfortable doing dialysis on their own, or having, there are some states where it's allowed to have a different nurse to come home that somehow the insurance cover it. Can you talk a little bit more about okay, that hasn't gone through yet. Okay, so yeah, definitely clarify that for us.
What happened is
in terms of because I see a few questions relating to that. Can somebody do dialysis at home alone? I know definitely PD and home hemo, I did those alone myself. And then what else have you heard? And then what about the nurses coming into the home to do that in support other than their clinic nurse?
I knew of a very wealthy real estate developer who hired a private nurse, came to his house, did his treatments for him. Most people don't realize when they're asking about a nurse coming to the home that it is possible to learn how to do the treatments yourself, that a nurse trains you how to do the treatments, and that nobody goes home until that nurse and you are both confident that you know what you're doing and you can succeed. And then somebody is at the end of the telephone line anytime if you need help, right? Did you ever have to call, Kyle? Yeah, occasionally, right? Mostly not.
Yeah, just a couple times, usually technical support. So
right.
It tends to happen late at night at about
Of
2 a.m.
course.
while treatment's happening.
Yes, this makes all of the sense. But, you either call the company that makes the machine if you have a machine issue and there is somebody there 24 hours a day, or if it is a personal issue like, I think I might have a clot in my access, or it's feeling a little hot and red and swollen. I wonder if I should go in. That's a nurse question. So you ask nurses nurse questions, you ask companies machine questions, but you're not home, you're not alone, even if you're doing home dialysis by yourself. You have a network of support that is behind you. And part of that, honestly, can just be fellow patients and care partners who are online and can answer your questions or tell you when you need to call technical support or when you need to call your own nurse and ask a real question. But, generally, insurance health plans in the US do not cover a nurse to come to your home and do dialysis for you. Very, very rarely. Occasionally, but don't count on it. Tracy,
Yeah,
I see
and
you.
Adam, have you had direct experience working with your teams in terms of training folks for peritoneal dialysis and also home hemodialysis? What are some of the things you do to maybe help with the nervous patients and care partners that start? I know some people like myself are sort of afraid of needles, and those needles are not that small. Can you give us an example of that and sort of how you overcome those with the patients?
Yeah, so my organization, USA Home Dialysis, right now, guys, we strictly focus on home hemodialysis. So we don't do PD yet. We will be offering that service line in the future, but right now it's strictly home hemo. And we do all training, everything in the homes. We don't use brick and mortar clinics. We travel nationwide and have all services. It's really an Amazon type approach where we deliver everything to the patient's home. So yes, we are very involved in hands-on training of the patient themselves if it's solo, the patient and their caregiver if there's a team involved, and also staff assist. So I can speak to all three of those realms. But really, going back again to the undertone, guys, of this entire conference, and that's what does the patient want, right? If they don't want the needle option, then the only other option with home hemodialysis will be the catheter, right? Because the graft and the fistula do require needle access, 2 needles, okay? So we do deal with people with severe needle phobia. We also deal with people who just don't want to deal with a surgically placed, access in their arm. I do want to segue just for a hot minute here and say there are non-surgical vascular access options out there. They're called endo-AVF. Both Becton Dickinson offers a Wavelink endo-AVF non-surgical fistula, and Medtronic offers a non-surgical endo-AVF fistula that they call ellipsis. So technology has really advanced to the point where there are non-surgical vascular access fistula creation methods out there, and thousands of patients. This is not, new hot off the press. This has been around for years. Thousands of patients are benefiting from non-surgical fistulas. However, you still need the needles to access those. So, Kyle, to your point, if there really is a needle phobia involved, and a patient just says, hey, what's best for me is I don't want the arm access, I just want the catheter, that's the way that you would go. But yeah, we do training, and no patient, right, do we fit into a box and say, you're going to be done in 2 weeks, or you're going to be done in 1 month, or you're going to take, we customize the service. And I think this is how every patient should be treated across the country is really, it takes an invariable amount of time per patient to really train them and get them competent, get them comfortable, and get them confident. So it's one thing to sign them off their competencies that they're able to do this and they can do return demonstrations back to you. But at the end of the day, is your patient confident that they can do this at home by themselves? And we don't leave till that box is checked. We want to make sure the patient is comfortable, competent, and confident doing this. And so again, our staff, very experienced, we go in and work alongside. But yeah, we teach the needling methods. We teach all the methods with the catheters. And again, it's really a customized approach that we take, and no, one size does not fit all, which has already been mentioned here on this platform too. So that's what we do.
I just wanted to jump into that as somebody. Now, I'm not on dialysis. I've never been on dialysis, but I was needle phobic from the time I was 4 years old. So I get needle phobia. I mean, I didn't have a flu shot ever until like 2 years ago. I fortunately got married after Wisconsin changed the law to not require blood tests anymore because I didn't want to have a blood test. So I do get it, and those are big needles and they're scary
Yeah.
needles. I can
Yeah.
also tell you that the way past needle fear is exposure to the thing you do not want. And you know what? It works great. I have had some health issues where I've had lots of needles coming at me, and they don't bother me at all anymore. And it's so much better. My life is just so much more calm without that fear because there's just so many places in your life where needles are coming at you. You know, there's vaccines, there's dental work, there's, you know, all kinds of stuff. So getting past that is absolutely worth it, absolutely possible. And Medicare even pays for needle desensitization therapy. So that's a Medicare covered benefit. If that's a thing you need, it's available. The needles are a means to an end. Nobody wants them just to have them. But if needles get you the life you want, it might be worth it. Most people find that it is. The other thing that people aren't necessarily aware of is those needles hurt less when you put them in yourself because your brain can only focus on one thing at a time, and it can't focus on pain and on getting that needle in the right place at the same time. So virtually everybody who puts their own needles in says that it hurts way less.
Yeah, Dory, I'll piggyback off of that and add of the accesses that we've discussed here, the fistula. The data shows, right? The empirical data in this country shows that fistulas typically last longer for the patient. You typically get the better cleaning, K2/V clearance out of a fistula because of the different flow rates that it will welcome and be able to tolerate. But this was asked in the thread about the different problems that accesses can have. And so typically your catheters and your grafts come with, again, based on the data, more complications versus your fistula, but there are complications with all of the accesses. So there is no one perfect access out there, guys. But in terms of the longevity and most patients that get transplanted do so with a fistula. I know the KDOKI guidelines, National Kidney Foundation do heavily promote fistula, but really, again, we're back to the right access for the right patient at the right time. So if for you, we've got USA Home Dialysis, and by the way, we do use the Tablo hemodialysis delivery system. We exclusively use Tablo. We've had a number of patients who are like, "You're not touching me with needles. That just don't even talk about it. I don't want you to even bring in a piece of literature here about fistulas and needles," and that's fine. That's where they're at, and we work with that. That's no problem. But it really is about what kind of access is best for you. We will make sure you're educated on it. And we would encourage you to take to the internet and take to support groups and NKF and American Kidney Fund. And there's all kinds of large groups out there, HDU, that can help teach you, train you, and give you anecdotal data on these accesses. But really, it's the right access for the right patient for the right time and the right reason is what we promote.
Yeah, thanks for mentioning about the support groups online. I know Dory and myself, we run some of the largest ones specifically on home dialysis, along with Home Dialyzer United, and we're also working with the different kidney foundation, American Kidney Fund, as well as National Kidney Foundation and the other groups in helping to support their various online platforms as well, and educating their other patient advocates. I saw several different questions in here in terms of when is it time to start dialysis. It's very individualized. So if you're in early stages of CKD diagnosis, stages 2, 3, and sometimes even 4, just keep on top of your labs with your different clinicians, and they will better advise you individually in terms of when it's best to start dialysis and when you need to be concerned about access or the type of dialysis that you need to consider, and give you the various treatment options in addition to the various tools we've already shared with you in this session and other sessions throughout the day. Also, typically dialysis start here in the US when your eGFR goes 15 or below, and that's when insurance tends to cover. And I see Dory has a little bit of comment we'll get to shortly, but typically that is the starting point. But nowadays, we also have a lot of nephrologists that are delaying dialysis start until eGFR goes much lower. She's nodding her head, so I think that's her point that she wants to share.
Yeah.
But insurance coverage typically start with Medicare and Medicaid when eGFR is 15 or below. That qualifies that. Dory, let me toss it to you. Go ahead, share some additional information.
So the National Kidney Foundation conflated stage 5 CKD with a need for renal replacement therapy, and that's not actually correct. And in doing so, what happened is doctors starting people on dialysis sooner than they used to. They began starting them at 15 or 14 or 13. And what happened then was a bunch of population data in multiple different countries that proved that that was a very bad idea, that people did much worse when they started earlier, and that in fact the death rate was considerably higher. And so it's not that dialysis should start at 15. It should not, unless someone has overwhelming symptoms, which is unusual that early on. Generally, the sweet spot seems to be between an eGFR of about 6 to 9. With people with diabetes, it tends to be a little bit higher because they tend to get symptoms a little earlier, but there is no advantage to starting sooner. People think, oh, well, I'll feel better. Actually, no, it doesn't really work that way. And it's not safe to start at 15. The numbers should not be what drives this. The symptoms should be what drives this. The symptoms are not usually bad enough at 15 to warrant starting it. And sometimes
very good points.
The difference between 15 and say 8 or 9 might be a year or 2 or 3 off of dialysis instead of on it. So it's a big deal for folks to be able to wait safely and not be sort of pushed into it just because of a number.
Yeah, very great points there. And of course, financially and insurance coverage sometimes is an issue for folks as well. On that similar topic, Adam, if I could have you talk about, so you mentioned earlier about what you folks do, and I appreciate you folks take the time with the patients and making sure they're comfortable and educated, not just that they're competent at the skill set for doing home treatment and dialysis. I think you mentioned something about your nurses being able to go to the home. How is that handled in terms of payments and insurance? Can you just briefly discuss that?
Yeah, so we do offer a staff assist model. Now, just to really define that, staff assist is where someone wants dialysis at home. In our context, they want dialysis at home, but they cannot do it by themselves, nor do they have a caregiver. So staff assist is where we literally assign them a staff member 3 days a week or 4 days a week, whatever their prescription might be. And we actually kind of like in center, but we move you home. It's a one-on-one staff to patient ratio. And now we're not, as far as I'm concerned, we're not getting reimbursed for that at this point. Right? I mean, Dory, that's what you guys kind of already talked about. There's some legislation being highly encouraged for monetary compensation for that. But otherwise, we go into the homes and do all training in the home. So yes, we do drive, fly. Again, we're nationwide utilizing Tableau, and we will come to the patient's home, which has been really convenient and encouraging and successful for rural patients in particular that have to drive long ways to get to a clinic. And really what we do is we eliminate the travel burden of the several burdens that we take off the plate, the big one being the travel burden because we come to you. But yeah, we provide staff, Kyle, to your question, in your home and do all the training from lab draws to dialysis treatment, training and execution, to shipping out your supplies, to access, assessing and monitoring your own vascular access. But yeah, we aren't a full-fledged staff assist model at this time. We really try and empower and equip and give control and convenience and confidence back to the patient Because really what we do best is equip the patient to do it by themselves, and then we move on to the next patient, right? And we closely monitor and support remotely. But yeah, we are really looking forward to legislation that's coming out surrounding nationwide staff assist models.
It should come out. There was a test that Medicare did in the 80s of staff assisted, and they found some fraud. It wasn't even very much fraud. I mean, honestly, I think that the usual dollar figure for Medicare fraud is something like, it's like $1 billion or more a year. This was some small number in the few millions, and Medicare threw out the baby with the bathwater. And for 50 years, we haven't had staff assisted payment for dialysis, and that's ridiculous. In Canada, they routinely do this, and it's very successful and very effective. And it lets people have better lives who aren't able to do home treatments by themselves. Uh-oh, Kyle froze.
I think Kyle's frozen.
All right, let's take over this session.
All right. I think I'm back.
You seem to.
Thanks for bearing with the technical issues, everybody. Appreciate it. Let's talk about a little bit about some of the emotional health, and we covered that a little bit when Adam and his team were talking about how they take the patient carefully through the process between competency of skill as well as making sure they're feeling comfortable. What other information and resources might be helpful for patients and care partners in preparing for different dialysis options? Let's talk about that for a moment. And then, Dory, do you want to start?
I'm sorry, I was answering Rappa, so I wasn't listening to what you said. I'm following the chat and you at the same time, badly.
Yeah.
What
other resources do we have to talk about? And this kind of serves as a recap of our session here as well. Okay. That maybe we haven't touched on that folks could, in preparing for dialysis options or transplant, that they could look into, because we have a lot of great questions and we obviously can't cover them all in here as well.
What a good question. That's a great question. So there are tons of resources out there. If what folks want to do is slow CKD, and if I were you and I had CKD stage 3 or stage 4, I would want to be doing what was in my power to slow it down. I would want to be exercising. I would want to be asking my doctor, I put this in the chat for somebody, I would want to be asking my doctor whether I should be taking sodium bicarb. Don't take anything without asking your doctor. Things that you take, even over-the-counter drugs, supplements, folk remedies, pickle juice, there are all sorts of things that are a very bad idea if your kidneys don't work well. Don't take anything without talking to your doctor. But ask your doctor about sodium bicarb, because there are a number of studies that show that it can slow progression of CKD. If you have diabetes, good blood sugar control can slow progression. If you have high blood pressure, good blood pressure control can slow progression. Anything that is good for your heart is good for your kidneys. We have booklets on life options that you can look at for free. They're PDFs about stage 1 to 3 CKD and stage 4, 5 CKD, and then also treatment. So lifeoptions.org, and there's a resources section. Just look under patient resources to find those. If what you need to do is choose a treatment, if you're at that point, if it's not, you can't keep stopping it, it's going to keep progressing, then we obviously highly recommend the My Kidney Life Plan tool, which is free and kind of in Spanish, as I said. It's Google Spanish. We're hoping to do a better translation, but for now, if English isn't your first language, it's in Spanish and it's in English. And the point of that is to match a treatment to your life so that you can have your best life. And I'm going to stop there in case we want to either take more questions or look at more of these things that are coming up.
Yeah.
Chat, because Also,
Let me toss it over to Nurse Adam Wilson there. If you could just recap also your company name, because somebody asked that in the room chat there, as well as what are some resources that your company offers for folks in preparing for different dialysis options besides what we talked about here?
Yeah, sure. So the company name, guys, is USA Home Dialysis. If you scroll down below the live screens here, there's contact information. I know Kyle's got his there. I've got mine. But literally scroll down below the screens there and you can have it. I guess I'll just post it in the thread as well, because yeah, a lot of people have questions about access, and Tableau and everything in between. So here, I'll just post it here. But I echo what Dory said, guys. You want to slow down that CKD process as long as possible. And dare I say this, you don't wish dialysis upon anybody. Okay, it's not something that like, yeah, it is what it is, right? When your kidneys fail, you need it to stay alive, but you don't wish it upon people, and so you want to prolong it as much as you can. Dory mentioned activities outside, exercise, get up and move, stay active, eat things that are kidney protective. And I mentioned this before, ask questions. I think the dangerous patient is the patient that doesn't ask questions and get involved. They're not informed. They don't take to the internet. They don't educate themselves on what's going on. There are thousands, and dare I say millions of success stories out there, guys, of patients who have done this well. Many are part of this platform today. Reach out to them, ask them, how do they do it? How have they lived so long? They're smiling, they're vibrant, they're active, they run businesses. I mean, it's great. Dialysis doesn't have to be as limiting as you think. And so again, I echo Dory and her narrative, and that's slow things down, slow your disease progression down. And again, I know we're running out of time here, but if you've got home hemodialysis questions, I'd love to answer that for you. I really am not a PD expert, so I don't want to pretend to be. I'm not gonna, I'll refer you to another resource. But yeah, I mean, we're having a blast at USA Home Dialysis, really bringing everything. Again, I said it was an Amazon type approach. We bring everything to your doorstep. We don't leverage clinics, so everything comes to you. And patients have just expressed and been responsive above and beyond with the services that we offer with Tableau. Again, Tableau is a very cutting edge, innovative, user friendly, simple, easy machine to use at home. And I'd love to talk to you more about that. Again, contact me if you need me. I'd love to be a resource however I can for you.
And let's switch gears a little bit here in terms of advocacy. Talking about that a little bit, and we talked about how education is empowering. I know when I started dialysis and sort of crashed into it, the only option was the acute hemodialysis at the hospital for over 3.5 weeks before I was transferred out center or outpatient into a hemodialysis clinic. And it took about 5 months more at in-center before somebody even mentioned the possibility of a home dialysis option back then in the day. And I know Dory, myself, and a lot of us have been working through the last decade in terms of promoting that, along with Home Dialyzer United and different kidney foundations, to talk more about the different treatment modalities and bring that back to the forefront again. And then now we're sort of at the other side where some patients and caregivers are like, oh my goodness, I just got this diagnosis, and why are you talking to me about doing all this by myself at home? I'd rather have a nurse and a professional do it. So certainly that's an option. But besides education, what are some of the other ways that patients could advocate for themselves, and also for patient if they learn about these different home modalities, whether it's peritoneal dialysis, home hemodialysis, the different providers are available, and the different cycler models, and maybe their own care teams, not as aware of specific models or providers. What are some of the ways that we could advise patients and their care partners to advocate more for themselves in terms of doing their treatment of choice, basically? Who would like to take that on?
I would. I think one of the things we don't do a great job of in this country is teaching people how to be patients. And you can kind of see why. It's like, well, where in school would you be where someone would say, this is how you become a patient? Nobody wants to be a patient. But 50% of American adults have at least one chronic condition. And chronic disease is different than acute illness. So if you break your arm or you have appendicitis, you seek good care, you do as you're told, you go home, you're cured, you're fixed, everything's back to normal. Maybe you have a scar. With a chronic disease, it doesn't work that way. And you need to know your body best. You need to know how you feel. You need to know what symptoms look like, what to watch for. Nobody else is necessarily going to know that you have something going on if you don't bring it forth to your care team. And that's your job. When you have a chronic disease, you have a job. You didn't ask for it. You don't want it. You can't give it back. You can do it poorly or you can do it well. If you do it well, you have the best chance of feeling as well as you can and living as long as you can. So you think about diabetes. I've had pre-diabetes for 20 years. I check my blood sugar every morning. I limit carbs. I take metformin, which was not easy to get with pre-diabetes, but I do. And, I'm keeping my numbers in check because my dad had diabetes and I saw how he died and I don't want to go that way. I don't want to have multiple strokes and end up in a nursing home. Nobody does. So when you have a chronic disease, you have a job. Nobody tells you have a job. I am telling you, you have a job. Your job is to advocate for yourself. Your job is to learn as much as you can about your disease and how it affects your body, about every medicine you take and what side effects that causes so that you can report those because maybe you need a different medicine or a different dose of a medicine. And your job is to think about what you want and then to use that as a frame to make your decisions so that you make decisions that fit your life and you don't make decisions just because you're afraid of the unknown. There's a whole lot of unknown here and it's very scary. That is totally normal. If you're not scared, I worry about you. This is scary stuff. But you got to get past the fear because fear-based choices don't tend to be good choices. Yeah. So you got to find the hope for yourself and then you got to go after it.
And Adam, quick in terms of the advocacy, and then we're going to have folks drop back over to the stage for the main session there.
That was phenomenal. I'm over here just cheering like, yes, Dory, yes, Dory, yes, Dory. No, who manages your lawn for you? Who cleans your house? Who takes care of your car maintenance? Who brushes your teeth? I mean, I love every bit of what Dory said. We have to encourage patients to own up, take the bull by the horns, and really direct and manage their ship, right? They are the captain of their ship, and their ship is going to go where they steer it. I mean, really. And so it is a little bit of pony up and manage your healthcare, and you now have a job. I love the way she put that. So yeah, that's step one is the control is in your lap, and you get to decide where you go with this control. But just like your home and putting on your clothes and brushing your teeth, and like I said, your car and your lawn, whether someone does it for you, you're still managing that, right? You're managing someone mow your lawn, you're managing a house cleaner to come to your house, or you do it. It's no different with your chronic disease. So I love that, Dory. Well said.
Likewise, I love what you just said.
And I apologize we couldn't hear more from Tracy from the patient perspective of myself. You folks could definitely reach us at our various social media and also contact information on our profiles. I'd like to thank our panelist, Dory Chantel from Medical Education Institute, and also Nurse Adam Wilson from the from his dialysis clinic there, helping us with great information that's inspiring. I see many of you comments similar in the chat that it was helpful and lessen your anxiety. Definitely check in with your own healthcare professionals. They know your individual labs, including your dietitians, on some of the dietary issues that we haven't really touched on. It is definitely a full-time job managing chronic kidney disease and also dialysis modalities. I've experienced that while working on dialysis. Just want to thank you all for joining us again, and we're going to go ahead and toss you all back over to the main stage for the rest of today's sessions. Thanks once again for joining us, and thank you for American Kidney Fund and Home Dialyzer United for sponsoring today's symposium and sessions here. All right, we're going to head out, and have a great day, folks. We'll stay on a little bit for the chats here. For anybody that has additional questions, I apologize that we couldn't get to everything, but as you can see, dialysis as well as chronic kidney disease could be a whole lot of things involved.